And good afternoon, everyone. I'm Casey Kaufman, and welcome to the virtual Prostate Summit. Today, the session is called Immunotherapy for the Treatment of Advanced Prostate Cancer, and we have Dr. Andrew Armstrong with us. Dr. Armstrong is an associate professor of medicine and surgery and medical oncologist in the Duke Cancer Institute at Duke University. He's a member of the Duke Prostate Center and a clinical and translational researcher in GU oncology. A mouthful, but I got it done. Thank you so much, Dr. Armstrong. At this time, I also would like to invite all of our viewers, because this is an interactive session, to type in your questions in the lower left side of your computer screen. We'll get to the Q&A at the end of the presentation, and we encourage you, because it is interactive and it is a session for you to get the most out of. It's an exciting time to be in this field, and we won't lose another moment. So Dr. Armstrong, welcome again to the virtual summit.
Thank you very much, Casey. That was a great introduction, and I appreciate the conference for inviting me here to talk about prostate cancer. It's indeed an exciting time with the changing paradigms in prostate cancer management, many new therapies, lots of questions about the appropriate sequencing and use in patients for these new therapies. And so I'm going to spend the next about 50 minutes going through how to place immunotherapy. And who would have thought 5 years ago that we would be talking about a vaccine or an immune therapy for prostate cancer, but here we are, and we're going to go over where it's placed. It is an FDA-approved treatment at this point. And so I'm going to advance the slide here, and I'd invite any of the audience members to ask questions, and I'm here for you guys as part of this virtual meeting. Here are my obligate disclosures. I received a lot of research funding from many of these emerging companies in investigational therapies in prostate cancer. Here's the outline for this talk, and I'd like to thank Dendreon for inviting me to be a part of this virtual meeting. The purpose of this talk will review castrate-resistant prostate cancer. The participants have obviously are already well versed in this from Dr. Kantoff's presentations, Dr. Mall, and many others who have talked about the appropriate screening and hormonal therapies, and eventually we'll get to chemotherapies and other targeted therapies for prostate cancer. This is going to be a focused session on immunotherapy, particularly Provenge, which is the only approved immunotherapy for prostate cancer. And we'll talk about the patient selection, the administration, the efficacy, and the safety from the phase 3 trials, and then get into some of the practical details about reimbursement and how patients can access this. So this slide really emphasizes the exciting changes in the clinical landscape of prostate cancer. And this is a graph which is essentially a cartoon of a patient who has failed local therapy and who is potentially a candidate for many of these systemic therapies. A man is typically diagnosed with prostate cancer, will undergo some form of local therapy. If he's cured, the PSA will typically go down to very low levels, if not zero, and remain very low for the rest of his life. He wouldn't be a candidate for this therapy. If, unfortunately, he progresses, that would be first noticed by a rise in the serum PSA. It's a blood test. And at that point, he would be taken care of by the urologist or a radiation oncologist, and often they would be referred at some point to a medical oncologist or continue to be followed by a urologic oncologist and treated with hormonal therapy in the form of what we call androgen deprivation. The first Nobel Prize in cancer medicine actually went to the discovery that prostate cancer was a cancer that's very dependent on testosterone for its growth and survival, and it remains our frontline systemic treatment for prostate cancer. However, it doesn't cure anyone, essentially, and it eventually the tumor finds an escape mechanism to get around hormonal therapy. And at some point, the patient will develop what's called metastasis. And metastasis is the manifestation or the visualization of the cancer that is spread beyond the prostate. That could be in a lymph node, a bone, an internal organ. All of those are extremely serious and require a more aggressive approach. And that's where Provenge typically has come in. It's recommended right now and FDA approved for the treatment of asymptomatic to minimally symptomatic men who have what's called castration-resistant prostate cancer. This term, castration-resistant, has emerged over time from the term hormone-refractory or androgen-independent prostate cancer, as we've learned that many new hormonal therapies are still active, and these men are essentially just resistant to the castration of the hormonal shots. Provenge fits in, as you can see here in this slide, often prior to the administration of more toxic therapies like docetaxel. There's still a great desire by men to put off more toxic therapies and to sequence these appropriately. And we'll go into the data about each of these. So here's the label. It's an autologous cellular immunotherapy. I said it was a vaccine, but it's actually not a vaccine. It's an immunotherapy. This is not a preventative strategy. This is a treatment. It's the man's own cells being given back. So when I say autologous, that's the patient's own cells. So this is a very novel therapy. This isn't an off-the-shelf prescription drug. This isn't a pill or a chemotherapy. This is the patient's own cells that are being stimulated outside the man's body and delivered back to that man. So we'll get into, so here's the overview slide. Here's where the power of Provenge has been shown in randomized phase 3 trials to extend life. That's the main reason we give it, and that's why the FDA approved it. And it's done so with a very favorable safety profile. And so the main question that I get from patients is, well, sounds great, but what are the risks? The risks are pretty minimal. Only 1.5% of patients had to stop because of side effects. The side effect profile is much like getting a blood transfusion, which many of us will get at some point, in which there are short-term side effects like fevers and chills from really your own cells entering your body. There can be some short-term transient side effects. The Nccn Guideline, which is our National Comprehensive Cancer Network, I sit on this guideline, and obviously when this got approved, there was great debate about where to position this. At the time, the data was in the pre-chemotherapy setting largely, but now it's largely for men, as long as they fit the label, who have asymptomatic to minimally symptomatic metastatic disease that's progressing despite hormonal therapy. So that's the label. Provenge is over and done with in 1 month, and we'll get into the practical details of the administration of that and the appropriate sequencing. So let's take a step back and go over the disease state that we're talking about, castration-resistant prostate cancer. It exists in a spectrum. I study a lot of biomarkers in terms of how to predict who's going to develop metastatic disease and progression and the survival of these men, and it's a very heterogeneous disease. You can have men who will have a very short life expectancy, less than 6 months, if they have a lot of pain, cancer that's spread to internal organs, and then you can have men who will live often for many years, 5 to 10 years, who have minimal disease, of a small burden of disease in their bodies. And there you're really talking about maintaining quality of life that they already have. Many of these men are working, and you probably know them. Prostate cancer affects about 230,000 men per year, and there's over 750,000 men alive right now with prostate cancer. Of those, a small subset are alive with metastatic prostate cancer, and of those, a smaller subset have castration-resistant prostate cancer, as you can see from this slide. The disease passes through many disease states, from localized disease to recurrent disease to hormone-sensitive disease to hormone-resistant disease to metastatic disease, and then even chemo-refractory disease is its kind of own state right now, which Dr. Sartor will be talking about. Many men will pass through a period of time where they feel great, but they've been told by their doctors that they better start planning for more aggressive therapy. This is really where Provenge is most indicated. And over 80% of men who have non-metastatic hormone refractory or castration-resistant disease will go on to develop metastatic disease. So it is a serious condition, one that ends up being fatal in many patients. The vast majority of patients are dealing with a life-threatening illness. So while it's not an immediate emergency, it's a chronic emergency and something that we need to take seriously. Matt Smith has published a lot of great data on the transition from non-metastatic disease, where you can't see anything on scans, to when that first spot will develop, when you can use Provenge, essentially. In his studies of the natural history of this disease, a lot of factors are important. Number one is the PSA. How high that blood test is determines how quickly the spots will show up, whether that's on a bone scan or a CAT scan. Number two is how quickly that PSA is rising. So that PSA test is very important, and we often will risk stratify our patients and guide the imaging and the frequency in which we do imaging to detect these. In the past, we haven't had a lot of reason to do a lot of aggressive imaging because we honestly didn't have therapies for those men who had asymptomatic disease. We just had chemotherapy that was often used for metastatic symptomatic patients. And this graph shows you that about 50% of men who have no metastases at the beginning will go on to develop metastases just in 2 years. So this calls essentially for the need for careful surveillance of these patients. And the next slide shows you that men who have a very rapid doubling time or a very high PSA will develop progression sooner than those men who have a very slow doubling time. And so I look at this data and can essentially predict when a patient that I see in clinic will go on to develop more aggressive disease that can be seen on scans. That would be the trigger at that point to consider a systemic therapy like Provenge. Often before Provenge, the systemic therapies that are used would be secondary hormonal manipulations, bicalutamide or other anti-androgens, ketoconazole, or other adrenal androgen suppressors. We kind of maximize that hormonal blockade until we finally gotten metastatic disease, and that's where the paradigm has changed. Evan Yu did a very interesting study where he was screening patients for a new systemic therapy. The trial was intended for non-metastatic patients, but as part of the trial they had to do scans just to figure out if you didn't have metastatic disease, and they found that a third of those patients actually had metastatic disease if you just looked for it. And so we learned from that experience that if you go looking, you will find it. And again, in the past we didn't have a reason to look. Now we have a good reason to look because we have a therapy that can extend life for those men. This next data comes from a Dendreon chart review in which many medical oncologists and urologists were polled to essentially determine when referral practices occurred. There has been a concern for many medical oncologists that they get patients very late in the disease process, and there's been a concern from urologists that they don't want to give up their own patients. They've been following them since the diagnosis. This is a multidisciplinary approach. It requires both the urologist and the medical oncologist to communicate about the best delivery of care to that patient to optimize his care. This poll essentially showed that most patients are showing up before symptomatic disease occurs, right generally at the time of metastatic disease. We try to get our patients at Duke at least a bit earlier than that because we do a lot of clinical trials. We have a lot of other things to offer. And I'll go into another chart review here. In this study, about 61% of patients had minimal or asymptomatic disease. That would be the Provenge type candidate. Some urologists give Provenge, many medical oncologists will give Provenge. There is no license to give Provenge. You need to be a clinically trained urologic oncologist who has experience in systemic disease management. There are many different options that can occur nowadays for the treatment of these men. I think it's just incumbent that if you're going to use Provenge that you have an expertise in it, and that's what this talk is kind of geared towards. So we'll spend the next period of time talking about, well, what does it mean to give Provenge? Okay. The good news is that most of these patients who are referred initially have a good performance status. So they are like you and I. They're healthy, they're working, they don't want to be bothered by symptoms or complicated treatments. They're willing to get intravenous medicines as long as they don't lose their hair, or maybe if they've already lost their hair, as long as they don't feel tired or sick because of the therapy. So the goal of these men is to preserve a good quality life that they already have. However, when you look at these men, you'll be astounded to know that the median survival for these asymptomatic individuals is still short. It's about 2 years or less. So in natural history studies of men who are not initially treated for their metastatic prostate cancer, the median survival, as you can see in this slide, was about 1.5 years to 2 years. That doesn't sound like a very long time. So another goal of these men is to live longer. You know, they're working. Many of them, they don't want to think about death at this point, although frank conversations do need to be had about the natural history and how we might be able to change that natural history with the appropriate sequencing of these therapies. So I think this is where we get to some discussion points about earlier diagnosis.
What about screening tools for MCR-PC? What's on the horizon?
Right.
What are you looking at, and what do you expect to see?
Right now, if you read the Nccn Guidelines, we're standardly doing CAT scans and bone scans. And patients who are not candidates for the contrast for the CAT scan, and MRI is a very reasonable substitute. There are emerging technologies to detect bone metastases earlier. The two most common places for prostate cancer to spread is the bone and lymph nodes. So tracers that are able to capture prostate cancer that are emerging are things like fluoride. You know, you put fluoride in your toothbrush because it coats your teeth, but it also goes into your bones and can image prostate cancer metastases, often in a much more sensitive way than bone scans itself. Other tracers are being looked at that are more metabolic tracers or even prostate-specific antigen tracers or PSMA tracers. So there's a lot of research into molecular profiling of cancer. I do a lot of work on circulating tumor cell biology. There's the hope that these very rare cells may be detectable in the bloodstream perhaps even before the metastases are visualized. And that instead of just counting the cells, you might be able to profile these cells and determine the right drug for the right patient based on his personalized kind of tumor profile. So that's what I spend a lot of time on. There's a lot of work that needs to go into all of these to credential them before they are incorporated into guidelines, but it's an exciting time. Okay, so let's go to the mechanism of action. How does Provenge work? The honest answer is really no one knows for sure. We just know that it does work. But I'll give you an example of a case of a man who's 72 years old. He's fairly emblematic for the man who will go on to receive Provenge. And when this guy, Mike, who's a retired engineer, was diagnosed several years ago, he had a rising PSA, saw his urologist, had a rectal exam, had a biopsy, was found to have cancer, and underwent a radical prostatectomy. And he had a very aggressive kind of T3 Gleason 8 tumor. Unfortunately, surgery was not enough for this patient, and within a very short period of time, his PSA became detectable and it rose, and he started on hormonal therapy. And he did very well for about 2 years. That's about one of the averages for men with very aggressive disease, is to have about a 2-year interval of disease control with what we call androgen deprivation. But his PSA started to go up again, and he had his initial bone scan was negative. A second bone scan was done once his PSA started to rise despite a low level of testosterone, and now he's got a couple spots on his bone scan. They weren't there before. They're not arthritis. He's wondering what to do now, but he feels great. Here's a cartoon of what is thought to represent the mechanism of action of Provenge. Provenge is an immune therapy. It involves removal of immune cells from the patient's body. These are officially the CD54 kind of antigen-presenting cells, cells that are normally there to fight off infections. They're not doing a good job fighting off tumors that are growing in a man's body. Obviously, it wouldn't be growing otherwise. These cells are removed through a process called pheresis, and we'll get into that in a few minutes. The pheresis procedure removes about 1% of that man's white blood cells that are circulating. And those white blood cells are sent off to a manufacturing warehouse where they're incubated with a cancer protein. And I'll show you some pictures of that. Those cells are then delivered back to the patient 3 days later. So this is a very rapid sequence of therapies, fairly complicated. When the immune cells are infused back into the patient, the way that they are theorized to work is that those immune cells have been activated by being incubated with the cancer protein. They then go on to stimulate the war horses and the soldiers of the immune system called T cells. T cells are important for many diseases, including HIV and infectious diseases, but they're very important also for cancer control. T cells don't work in a patient who has advanced cancer. Particularly, they don't work against your cancer. So the Provenge's design is to stimulate the T cells to make an anti-cancer immune kind of repertoire. And so that's how they're thought to work. And this requires essentially 3 procedures over about a 1-month period. So what happens is you start with a resting T cell here in this picture that gets stimulated by this immune protein called PAP. That stands for prostatic acid phosphatase. That leads to an activated dendritic cell or antigen-presenting cell. That's what's given back to the patient. So the patient, even though 1% are removed, he gets those cells right back. So it's a loan. That loan is then kind of amped up with the cancer protein, PAP, and those immune cells then go on to train other cells. So they kind of pay it forward and go on to other T cells throughout the body to then attack the prostate cancer. So that kind of priming has actually been measured, and if you read the New England Journal paper that was published at the time that Provenge was approved, the phase 3 trial actually had immune monitoring as part of that. These are research studies. They're not available clinically, but you can see in this graph that T cell and B cell responses to the cancer protein PAP were observed. They don't happen in everybody. Some patients may be more resistant to Provenge. Some patients may be very sensitive to Provenge. It's a little bit hard to predict. But about 28% of patients developed B-cell antibody responses. Antibodies are these little carrier molecules that attack the cancer protein that you're being stimulated against. And about 27% develop T-cell responses, the helper cells that go on to help kill those cancer cells in the body. And so that's a good number. Obviously, the placebo patients didn't respond at all, so it was good to see a real difference there, and that suggests the mechanism of action of this immune therapy. One of the theories of immune therapy is that it's very unique and not the same as chemotherapy or hormonal therapy. When I give a man a hormonal shot or a new hormonal drug, I expect his PSA to go down and his tumors to shrink if he's going to benefit. Same with chemotherapy. If I give a man Taxotere or docetaxel or cabazitaxel, I expect his PSA to go down and his pain to improve and his tumors to shrink if he's going to benefit. With immunotherapy, there's quite a lag period of time as those immune cells are being trained to fight off that immune tolerance and to promote an anti-tumor effect. In fact, that immune response may take many months, and the patient could have gone on to other therapies even after the Provenge has been delivered. And James Gulley's group in the NCI has postulated that this immune therapy benefit is only detectable by measuring kind of the rate of growth of the cancer over time, which is kind of represented in this kind of blunting of the rate of growth of the cancer cell over time. And so getting a PSA right after Provenge, you're not going to be surprised that it's gone up. Getting another CAT scan or a bone scan right after Provenge, it's going to look worse. Okay, that's what is expected. You give the Provenge because of the survival benefit in the hope that the overall progression of the disease may be slowed or the outcomes of the patient will be more favorable than as if you didn't give it. And so immune therapy works differently. It primes the immune system. It elicits a delayed immune response that can then help other therapies later work. So let's go over the efficacy. Why do we give Provenge? We wouldn't be here if it didn't improve survival. But it took a long pathway for Dendreon to get to survival. It all started with phase 1 trials, just trying to figure out the appropriate tumor antigen, the mixture of the immune adjuvants that are used to stimulate the immune system, and the proper dosing and sequencing of this. This led to phase 2-3 studies where Provenge was studied kind of head-to-head against a placebo or a sham pheresis. And that was when the first trial really reported a positive result. Unfortunately, the trial was not designed for survival. It was designed to detect a response and a progression benefit, and that was negative. So the FDA did not approve it, but the survival of those men were longer. So the FDA said, we'll do an additional study and we'll see what we see. And the IMPACT trial was the result of that discussion, and that was when the IMPACT trial in 2003 was launched, now with the primary endpoint of overall survival, which remains the true benchmark for endpoints in this disease. It was just over the past year that this was approved. So here's the trial design. Again, just like the label, these men had minimal symptomatic disease. They were not taking narcotics for cancer pain, or they were asymptomatic completely. These patients did not have visceral metastatic disease. They were not taking immune suppressive drugs. They were generally healthy and had good performance status. It was a randomized study, so in a 2-to-1 odds, the men got either Provenge or they had their immune cells removed and part of them were given back or frozen for later delivery in a kind of a crossover design. So the Provenge was given 3 times over that 1-month period every 2 weeks. And then they were simply followed at the discretion of the investigator. Other therapies could be delivered, and the primary endpoint was how long these men lived. There was a crossover design. I'm not going to go into the crossover data here, but suffice it to say, crossover was allowed, so some of the product was frozen and could be given and was given to many of the patients even on the placebo arm. So essentially this trial was comparing early versus later Provenge. Okay. Again, the primary endpoint was overall survival. About 64% of the control arm crossed over. So you can imagine that even that design would challenge you to get a positive study if over half of your patients are also getting your agent. The typical profile of a man who was on this study was a Caucasian, good performance status, fairly healthy man who had a PSA on average of about 50 and who had bone metastases or lymph node metastases. Again, no liver or lung metastases were permitted on this study. There were a small subset of patients who had prior chemotherapy, There was a washout period required for that, and you could be on other agents such as bone health drugs, and all men continued on their hormonal therapy during this time. So this is kind of the main slide of the whole presentation. This is the phase 3 trial data. The primary endpoint was met. The hazard ratio, which is really an estimate for how much longer men lived, the risk of death over time was improved by about 23%, so hazard ratio of 0.77. Provenge men lived on average about 4.1 months longer than the men who did not receive this. You can put this in many ways. You can say, well, if you're a man, 4.1 months doesn't sound like a long time. But you could also say it in a relative respect. It's about a 25% improvement in your life expectancy. There it sounds a little better. If you know you only have about 2 years to live, 4 months sounds like a lot suddenly. And if you put it as part of an overall strategy to offer men a sequence of therapies, each of which improves survival by about that much, sometimes more, now you're talking about perhaps years of additional life. So this is not used in isolation. It's used as part of an overall therapeutic strategy. So again, 64% of patients crossed over. So if you consider the lack of crossover, it's possible that the survival benefit could be greater. However, this was the way that the trial was designed, and this is the result. If you can also look at it as what is the chance of you being alive at 1 year, and at 2 years, and at 3 years. And in each case, it's higher with the Provenge patients. So this is something that is used as part of the discussion is why you would ever go and embark on this immunotherapy. So the chance of being alive at 2 years was 26% greater if you had Provenge and 37% greater at 3 years as compared to the sham pheresis group. If you put all the studies together, the phase 2 and the phase 3, you see a consistent signal. The survival benefit was better in both trials. If you do a meta-analysis of the data looks quite profound and consistent. A p-value that meets everyone's criteria for not likely from chance. And the hazard ratio is consistent between the trials. The next question is, well, that's the efficacy data. What's the safety data? Let me just spend one more minute. I get a lot of questions from the audience. Well, what else can I expect besides survival? Okay. You should know that, as reported in the New England Journal, you do not see PSA responses. You don't see tumor shrink. There is not a delay in progression-free survival, meaning radiographic growth rates. You give this as a survival drug, much like you give adjuvant chemotherapy in breast cancer and colon cancer to prevent death from later occurring. It's given to reduce the probability of a future event, which is death, from occurring, and that's where it's a positive trial. The other metrics, progression-free survival, PSA declines, are not perfectly correlated with survival, particularly for these immune therapies. And so we don't rely on those. We simply give it with the hopes that enough men will benefit in our community if we give it enough. So what's the risk to Provenge? The next question. I mentioned in the beginning that it's a very rare patient who has to stop therapy early. We give a lot of Provenge here at Duke, and our experience has been very favorable and similar to this published experience. That generally dose adjustments are not required, that patients are able to get through the pheresis successfully and then on to other therapies such as chemotherapy or hormonal therapies. The side effect profile is extremely favorable as well. Some patients have chills, about 53% compared to 10% with the controls, but the chills are short-lived. They're generally gone by 1 day. And they can be treated with Tylenol, Motrin. Sometimes you have to reach for Demerol if it's a real shaking chill, but they're not dangerous or life-threatening. They're just uncomfortable if they occur, just like a blood transfusion. Same with fatigue and a low-grade fever. It's much like feeling like you have the flu for about a day if you were to get it, but most patients don't have a severe reaction. The rate of hospitalizations is extremely rare with Provenge. There are some headaches that can occur. There's some citrate toxicity, some mouth numbness that can occur during the pheresis procedure. I would say another side effect that comes up is the kind of pain of having to go to the Red Cross and get a needle stick, and then sometimes men will need a central line or a large catheter if they have difficulty with IV access. That central line comes out after a month though, so it's a short-term pain for a long-term gain, hopefully. Majority of adverse events are mild and moderate without life-threatening problems. So 92% again received all 3 infusions. It's about only 10 or 20% that have to get a 4th infusion because of a problem with one of the first 3. that's becoming increasingly rare as more experience is developing in these centers for the safe administration of this and the pheresis. So serious adverse events are very rare. There is a registry ongoing right now to fully detect, rare events. Things like chills, fever, fatigue, shortness of breath, allergic reactions, headache, are all very rare, and none of these are life-threatening in general. They're very short-lived.
Since Provenge was launched initially, the patient selection was rather restrictive.
Yes.
What about today? Where are we?
When we first gave this a couple years ago, we were only allocated about 2 patients per month. And you can imagine a big center like ours, we have patients coming from the whole tri-state area, even from California, looking for this. We were one of the first infusers. And we had a wait list that went on and on and on. We had to make some rationing decisions. We've published a paper on this now, and about some of the difficult choices that we had to make about the appropriate man for Provenge. Fortunately, we were able to treat all those men, and the wait list shrunk very quickly as Dendreon opened new factories and as other centers started to be able to acquire the capability of working with the Red Cross and delivering Provenge. We now have no wait list. We don't have to make those hard decisions.
Before you go on with your
Yes.
presentation, which is excellent, by the way, rationing, I imagine that has to be one of the hardest decisions to make as a doctor. But where are you today
Right.
with regard to rationing?
Right now, there is no rationing, so that's fortunate.
And a huge relief, I imagine.
Yes, certainly there are issues beyond the scope of this discussion about cost effectiveness, but we are not at this point in our healthcare system having to make decisions around cost with Provenge. It's gone through a national healthcare decision. Medicare has ruled that the favorable risk and benefit has led to the approval. The FDA has approved this. We can use it without necessarily concerns over cost. And Dendreon has many mechanisms in place to cover those who are unable to afford it, either through copays or through lack of insurance, for that matter. So that's very reassuring to us. And we don't have to convene ethics boards now, much like organ transplants, to say who's going to get Provenge and who's not. We can generally offer it. We do have a Provenge coordinator at our center, so someone who's a nurse who really works with our patients to educate them, to coordinate the Red Cross and the pheresis schedule. It is fairly complicated when you think about Provenge as compared with other therapies. This is very different. This is not write a prescription and see you in a month. This requires an intensive coordination for the patient. They're in a Red Cross chair 3 times. They're back in your infusion center 3 more times. There's that 3-day window where if the Provenge is not given, it is not a good product anymore. So you essentially have a very short time frame. And then you have to think about the sequencing of therapies all around it. So I'll go into some of those practicalities now. So here's patient selection and administration. Obviously, all patients need to be treated on label. Okay, that's the most important point. On label means they have to have metastatic disease, so that's some sort of radiographic or clinical sign of metastatic spread. They cannot have symptomatic disease or such rapidly progressive disease where there's an immediate concern for something life-threatening, where chemotherapy might be better indicated. And if you look at our NCCN guidelines, the main branch point for these men with castration-resistant disease is whether they have pain or whether they have visceral metastatic disease. And if the answer is yes to one of those, we consider chemotherapy probably as the initial therapy. But if the answer is no, and they have minimal symptomatic disease and no cancer-related pain and no visceral disease, particularly liver metastases, then Provenge would have the level 1 evidence to support its use in those men. So here's the NCCN guidelines kind of simplified, where men with asymptomatic, minimally symptomatic disease, no liver metastases would be highly considered for Provenge, and patients who have symptomatic disease and who are at imminent risk of very life-threatening progression are probably best given something that has a short-term benefit, like a cytoreductive drug like docetaxel, perhaps abiraterone that's emerging in phase 3 trials right now. That doesn't mean that they can't get Provenge in the future, and we'll talk about men who have already had chemotherapy, who can go on to get Provenge later. So the therapies that are indicated for advanced castration-resistant prostate cancer, Provenge is really the first drug to have a symptom in its label. So asymptomatic, minimally symptomatic disease. Docetaxel cabazitaxel, abiraterone, all come with steroids. So you do have to be a little concerned that you're giving this very complex immune therapy and then following that with a chemotherapy that has some immunosuppression with it. So we'll talk about the appropriate sequencing in just a few minutes. So I tend to use Provenge when I see the man starting to fail hormonal therapy before they've developed symptomatic disease, when the patient has some time to spend a month getting this immune therapy where they don't need that short-term reduction in disease. And that takes advantage of the fact that their immune system may not be as compromised as later, and that they can safely get this without having to worry that they're going to need chemo the next minute. Okay. Obviously, patients who have a larger tumor burden may have a more impaired immune system, so you want to give that patient the best chance that they can to receive it. And so this case patient that we presented was treated with Provenge, and so the next question is, well, how do you educate the patient? What is it like to get Provenge? We were on NBC Nightly News, actually, when this drug was approved, and I had one of my patients who was highlighted on that, and it was a very exciting time. He was followed to his house, and they went through the whole process, so I'd encourage you to see that if it's online. But essentially, it's a process that involves generally two institutions. One is the Red Cross. One is the infusion center in your local hospital or treatment room. The Red Cross is the collector of white blood cells. The leukapheresis involves the insertion of a peripheral IV, being hooked up to a machine that removes a small percent of white blood cells. It returns the other good cells, and most of the white cells are again returned to you later. That product, the blood product, is sent off either to Atlanta or on the West Coast or to New Jersey, where Dendreon has a laboratory that is a patient-centered laboratory with good clinical practice, and they essentially mix those white blood cells of a man with this cancer protein that's expressed in over 95% of prostate cancer cells. And that enrichment, that stimulation of that man's white blood cells is then returned to the patient, often through an airplane flight. It's a 3-day process, and 3 days later the patient's in your treatment room waiting for that Provenge to be delivered that morning. The patient gets some Tylenol and Benadryl, and away they go with a 1-hour infusion of their own cells, but now they've been stimulated back to him. You don't need to worry about adjustments for kidney or liver function. It's a very well-tolerated therapy. We tend to observe the patient for about 30 to 60 minutes afterwards, give them Tylenol and if they have an infusion reaction. So here's the calendar. You can see if they start on a Tuesday, they complete their first dose on a Friday, and you repeat that every 2 weeks. So basically 1 calendar month, you're done.
It's remarkable when you factor in immunotherapy, safety profile, short duration of therapy.
Right.
What are your thoughts on the appropriate sequencing? Will remain consistent, or,
Right.
or will you be looking at something different?
It's going to change over time. Right now we don't have other approved pre-docetaxel drugs that have improved survival. Survival is the main metric that everybody wants. There will be data coming out likely over the summer that we'll see with abiraterone, but we haven't seen the data yet. There will be emerging data over the years with other drugs in this space. But Provenge is unique. It's an immune therapy. It will complement our existing therapies. It largely won't be replaced. So the right question is, when do you give it? And that's generally very early on, when you don't need to have these other drugs in your system. These other drugs often have other side effects. They come with steroids. Steroids suppress the immune system. We tend to want to give the Provenge as early as possible when the immune system's still working.
And you talk about the cooperative
Right.
nature, where it really needs to be across terrain.
Absolutely.
So that the doctors are
with the urologist
exactly
involved in the decision.
Earlier on, is that in a best case scenario, is it to anticipate and be proactive?
Yeah, having tumor boards, just having collegial relationships, talking about a patient when their PSA is starting to go up, getting scans, documenting that metastatic disease exists, and then having ready access to a Red Cross and a pheresis center. The timing around chemotherapy is a little more controversial. There were some patients in the IMPACT trial who had prior chemo. The label does not mention the word chemo, so you can officially do it. However, you have to be careful because men who have already had chemo have more aggressive disease. And they've also just had their immune system suppressed by the chemo. They're on steroids. There's often not a lot of men who can spend a lot of time off chemo at that point. And so it is a select group of men who have generally been able to stay off chemo for a few months. Their PSA has been responding. They're taking a holiday from their chemotherapy. They're going back onto some other therapy after Provenge, but that's an ideal time when they're still asymptomatic or minimally symptomatic to get that survival drug in. So that's the ideal strategy for those men. There's still a lot of men who've already had chemo where they didn't have an opportunity pre-chemo to get the Provenge.
That's what I was thinking. So, can you still offer it and get in on that?
We don't mix it with chemo.
Right.
We don't want to give it with steroids. We don't want to counteract the effects of Provenge. But this is all about sequencing. Reimbursement, is a common question. We went through a 6-month national coverage decision with Medicare. Medicare is covering it. At our institution, we've generally had no problems with reimbursement. Often there is information that's requested by these insurers about the documentation for having a low testosterone, for metastatic disease, for appropriate blood work. The Red Cross has its own criteria for being able to do a safe pheresis procedure, for example, having a relatively normal hemoglobin or not too low. And generally, reimbursement has been fine, and it's not been a major barrier for giving this. I'll just highlight that the out-of-pocket cost to patients was initially a big concern, but has not generally borne any fruit. Many patients are having very little out-of-pocket expense, many zero. Sometimes the cost of Provenge is less than the cost of a prescription drug like abiraterone. So it's kind of amazing. That's the way our health system works. It may not make any sense, but that's the way our society is structured right now. So,
and also the fact that it flipped from having a rationing experience.
It has flipped entirely, and it's now generally covered, and there's copay assistance. And even if you have no insurance, Dendreon has a patient support program for you, and there's a number of copay assistance programs that can help if your supplemental is still leaving you with a very large bill that you can't afford.
How has that Q code and NCD affected your practice and patients within the practice?
Essentially we don't have a wait list, and patients are getting their education, and within about 2 weeks they're receiving Provenge, and we have not had a problem with reimbursement. It's streamlined things quite a bit. Dendreon On Call is another support system. They can help with the coordination. We also have people at our institution, coordinators that really can work with Dendreon On Call to really coordinate it, to know if the product is good, to infuse it, to bring the patient back and coordinate those 3-day visits, and then essentially handing the patient back to the provider when the Provenge is delivered to talk about the next step. So Provenge is part of the package. It's not used in isolation. It's used as part of an overall kind of systemic strategy.
I think the big question is, and I'm sure people are thinking, is there anything in the future, biomarkers, blood tests, to determine who might be the perfect candidate and who might not be?
That's certainly the holy grail of all of cancer medicine. We've seen it in lung cancer. Certain mutations predict for response to certain drugs. Colon cancer the same way. Prostate cancer has lagged behind a bit. Even in breast cancer, we've had estrogen receptor, HER2 testing, drugs that have targeted those that really only work if you have that marker. Prostate cancer, that's starting to come out. Some of our hormonal therapies, we're developing predictive biomarkers. Immune therapy is a little bit more challenging. All of us have immune systems, but what is it about certain patients' immune systems that makes them not respond to Provenge? And some have a really great prolonged disease course where their biology suggests they may be around for many years and not even need chemotherapy.
It's not unlike HIV patients in some ways. Those patients that will present.
It certainly could be. I mean, you have some patients
live for decades, and
absolutely,
those who
even
don't.
without antiretrovirals.
Exactly.
So there is something about individual immune systems that is incompletely understood. I showed you some of the correlated data. Some patients have a great T-cell response. Why is that? I think we need to understand that better. Right now, it's in a research setting. We don't have that immune monitoring in the clinic. So there is not a blood test that you can point to, a circulating tumor cell, a PSA that will say, you got activated by Provenge, that you're going to live longer. We simply give it, much like you give Zometa, zoledronic acid, or denosumab as a bone drug to prevent the probability of something. It's not an immediate short-term benefit. It's a long-term role that Provenge is playing for these patients.
And the imaging issue, you said, is huge. I mean, if you see it, if you build it, they will come. If you see it,
that's right.
There's almost a correlation between greater awareness through imaging in terms of treatment. So do you see that as part of the big picture as well?
I hope so. You know, certainly you don't want to just do imaging for imaging's sake. You want to have something you can offer the patient once you find some bad news. You can counter that with some good news that now that we've seen that we can do something about it. Yep.
And continue.
Okay. Well, I think here's the summary slide. So obviously this patient received Provenge. He got good supplemental insurance. Maybe he paid $50 for his Provenge. And he's now moving on to the next therapy. And I think Dr. Sartor is going to talk about some of the next therapies that are coming down the pipeline after Provenge or sequenced around Provenge. Provenge is going to be here a long time. It's very hard to have a generic self product. You know, it's very individualized therapy. And it's very exciting to have an immune therapy. It's really the only sort of immune therapy for cancer other than maybe interleukin-2 for kidney cancer. But this is a very patient-specific immune therapy, the only one of its kind. And obviously we hope other cancers will start to respond to these kinds of approaches as well.
When you think about this as being just sort of on the great frontier where you're using, you know, you obviously it's your immune system.
Yeah.
Where do you go from here? What, as a researcher, you know, what do you think is out there on the horizon?
Right. There's certainly other immune therapies that are being studied. Provenge is the patient's own cells. It's very complicated. Can you do this with just somebody else's cells that are kind of radiated or placed into like a viral vaccine or some sort of off-the-shelf vaccine, and that's being studied. Can you also learn from the experience of the patients who got Provenge, who's likely to benefit, so you can maximize benefit, minimize harm. This is really the first generation. You know, hopefully the next 10, 20 years we'll have a sequence of various ways to combine Provenge with other drugs, looking at other immune approaches, maybe other antigens that may be more immunogenic.
That you would then almost in a customized way. I mean, if Provenge is given and the PSA level doesn't change and the tumor stays the same, but you're looking at lifespan.
Absolutely.
But if the sequence could be affected and there was another drug that could be used in the third stage of a sequence, that's the piece.
We have all these new drugs, we just don't know the best way to deliver them in the sequence. So even understanding the right sequence of the ones we have is the next step as well. That's in the more immediate horizon.
In terms of your patients, you have been involved with Provenge for a long time. So early patients, their experience and what you've learned from them.
I've found generally that it's very well tolerated, that our patients are able to get through the therapy without major complaints. Sometimes they'll have the fevers or chills, the shaking, and that's memorable, but it's short-lived, certainly compared to the side effects of docetaxel with neuropathy and fatigue. It seems to be very well tolerated. Our men are living longer and longer, and so many of our first patients who got Provenge, they're still alive and they're doing fairly well. They've gone on to other therapies, but fortunately we've had other therapies there to catch them.
So when they come in to you and they are a candidate for Provenge, it's a finite, it's a short window that they're going to be treated and then followed.
Oh yeah, we don't release them.
Right, they're not gone into the...
We're not a Jiffy Lube for Provenge. We're a, we certainly will treat the man and then we think of the next option and the next option. And many of these men will get a sequence of 5 to 6 drugs over their lifetime.
That's what I was curious about. Is there a typical, I'm sure there's no typical patient, but they come in, they have this finite period where they know they're going to come in, they have the Red Cross chair, they're going to have the bloodline, they're going to be sent to a lab in LA or in Atlanta, you're going to see them for a month. You're not going to necessarily see anything in lab results.
You don't.
At all,
Nope.
But you now have this, you're able to track and say, we're confident this is adding time onto your life.
That's right.
Who goes to the next sequence of drugs and when?
They all do. It's just the timing is different. You can have a patient who can get the Provenge and that may be all they get for a 6-month period because their disease is growing very slowly versus a man whose disease is growing quickly, where as soon as you get that first scan after Provenge, you have developed more metastatic disease and rapid progression, or maybe you've developed symptomatic disease at that point, and the indication for using abiraterone or docetaxel is largely the same as if you didn't give Provenge, although there is some concern that by giving steroids or immunosuppressive drugs, you may counteract the Provenge you've already given. You have to make the right decision for that patient in front of you. If they have symptomatic disease, you really need to start another treatment that's going to give that short-term benefit and palliation.
Well, good transition to get into the rest of your presentation then.
So this is really the point where we summarize things. It's the first and only FDA-approved immunotherapy. It extends median survival beyond 2 years, a 23% improvement relative, 4.1 months, absolute improvement. Some patients benefit more than others, clearly. 1.5% adverse event profile leading to discontinuation. Overall, a very safe therapy, and now part of our NCCN guidelines for the first-line treatment of men with asymptomatic or minimally symptomatic disease. It's all over and done within a month. It's now just part of our overall strategy for these patients. And so this is where we have some audience time for questions. And if there's anything that's pressing, we can answer them.
I think that people will probably want to know very tiny percentage of patients have adverse effects.
Right.
And impossible to predict, but it seems that it's a highly manageable situation. Have you had to take patients off altogether? Is a certain subset that just...
The biggest concern is disease progression during the Provenge. I mean, once you see a patient, you decide they're a candidate for Provenge, you start that process of coordination. It may take a few weeks, and then it takes about a month to give the Provenge, and then you see them back a couple weeks after you're done with Provenge. That's a good 2-month period between when you've gotten a scan and when you see them back. There are some patients who progress quickly, and I have had some patients who have progressed while they've been getting Provenge, and that can be scary. That's where patient selection comes in.
Because you're doing nothing in that time frame other than Provenge.
And Provenge is not expected to have that short-term benefit, so the appropriate patient for Provenge is one who's
feeling pretty good.
Is feeling good, and they're not at imminent risk. So we've learned a lot by the patient selection criteria. We've not seen major adverse events. Obviously, there are some patients who have really difficult IV access where you might warn them that they're going to need a central line, and that's not very desirable if you have to go to work and you feel, no symptoms. And
but a month is probably a lot easier to handle than...
It requires some home care and setting up and flushing of the central line, but it's doable.
And I know that there are other researchers working along the same lines. In fact, we're going to be listening to Dr. Sartor from Tulane soon about chemotherapy, I believe. So a big part of this is to be synergistic, is to have that kind of collaborative community of research and expertise, I would think.
Absolutely. It's been a great time for our field. We went from about 7 years with no drug approvals from 2004 till 2011, and suddenly we're blessed with 6 new drugs, some of which will be approved in 2012 and are not yet approved but are coming.
And what do you think it is? Just a perfect storm of things happening in labs?
Investments in research that are now paying off. The war on cancer started in the 70s. It does take a long time to move from basic science research, as I showed you with the time frame with Provenge, for example. It took about 20 years to go from the early trials to approval. We're in it for the long haul, and we're starting to see some of those results pay off, and hopefully our healthcare system will continue to invest in research, particularly for cancer.
And as you can see, even if you're talking about that period of time, the importance for patients to get on a drug like this it can't be understated.
Right, can't wait.
Well, I thought this was one of the most interesting and informative sessions, and you answered so many questions and really got through, covered a lot of territory. So I'd like to thank you, and I'd like to thank our sponsor of this session, Dendreon, for their participation in this virtual prostate summit. It's been a pleasure talking with you today,
it's been a pleasure,
Dr. Armstrong.
Thank you.
I'm Casey Kaufman, and don't go away. We have another virtual summit that's about to get underway from Tulane University. Dr. Oliver Sartor will be coming up next, so don't go away. Thanks very much.